what is non-bacterial thrombotic endocarditis? It is also known as aseptic endocarditis. It used to be called as verrucous endocarditis. The first description of sterile vegetation on the heart valve was given by Ziegler in 1988. And then Libman and Sachs then published a case series of 4 patients in 1924 which associated these atypical lesions with SLE. Gross and Friedberg coined the term NBTE, and it is defined as vegetations on valve surface rich in fibrin and platelet aggregates, but devoid of inflammation or infective organism. So who is affected? Which class of patient? Most often, the diagnosis is postmortem, with rates in autopsy series varying from 0.9 to 1.6. However, some are diagnosed antemortem also, presenting with symptoms of systemic embolization. Any age group can be affected, most common between 4th and 8th decade, and there is no sex predilection to it. Patients with advanced malignancy and SLE are the most common, the ones who are affected. Now, what are the conditions associated with NBTE? We have a plethora of conditions, in fact. In SLE, 4 to 43% of prevalence. In antiphospholipid syndrome, 41%. In malignancies, 19%. And out of the malignancies, most frequently are the adenocarcinomas, then pancreatic cancer, and likewise. So, coming to some elaborate list of causes of NBTE. Talking of malignancies, we have mucin-secreting pancreatic adenocarcinoma, lung cancers, ovarian cancers, colon cancers, prostatic cancers, cholangiocarcinoma, and lymphoma. Then in autoimmune disease, we have SLEs, antiphospholipid syndrome, vasculitis, and I think all types of vasculitis can have it. Hypercoagulability states, protein C and S deficiencies, DIC, thrombotic microangiopathies, TTPs, and catastrophic antiphospholipid syndrome. And we can have it in chronic inflammatory state also, like tuberculosis, uncontrolled HIV, chronic pyelonephritis, and chronic osteomyelitis too. Then there are some other causes like hypereosinophilic syndrome, chronic alcoholism, renal insufficiency, heart failure with valvulopathy, and toxic oil syndrome. It is a separate entity to the culture-negative endocarditis, which is due to infectious etiologies that are not readily identified. So what is culture-negative endocarditis? Because of maybe previous antibiotic treatment we get it, or maybe just microbiological diagnosis missing, or in patients with acute renal failure, or with some VSD, ASD, and cardiac post-thrombi, and also unusual microorganisms which we know, Brucella, Coxiella, Bartonella, all these are big list. So what do we see under microscope? What is this? The vegetation in NBT consists of thrombi, interwoven with strands of fibrin, immune complexes, and mononuclear cells. So histological sections, they show thrombotic vegetations. We don't see any inflammation. And histology of vegetation demonstrating a web-like mesh of fibrin and platelets in the B. So basically, immune complex, carcinomatosis, and hypercoagulable state, they all cause overlappingly NBTE. Endothelial injury in the setting of a hypercoagulable state is thought to be critical for development of this. Endothelial damage is initiated by circulating cytokines like TNF, IL-1. They may trigger platelet fibrin deposition in presence of an activated coagulation system, DIC, antiphospholipid syndrome, and malignancy. Now the famous word, the Libman verrucous endocarditis. Vegetations vary in size from microscopic to large and exuberant. When thrombi are large, the term verrucous endocarditis is used, and also known as Libman-Sachs endocarditis. So if we describe it grossly on pathological terms, they are typically small, friable, white or tan masses less than 1 centimeter in diameter, broad-based and irregular, usually along lines of valve closure on leaflets, which may be normal or previously damaged. Based on morphology, Allen Sirota proposed a macroscopic classification. Type 1, that is small, less than 3 millimeter, and univerrucous, formerly at S2 valve. Type 2 is large, more than 3. However, univerucil, type 3 is small, 1 to 3, and multiple. Verucil, it is friable because it's multiple varices. Vegetations are more easily dislodged in comparison to other vegetations we are hearing in other sessions, since there is little inflammatory reaction at the site of attachment, and so greater embolization, and it may cause extensive infarction. The 3 times more cerebral microemboli events per hour with the vegetations than those without vegetations. So most common involves the surface of mitral and aortic valve, but all four cardiac valves, endocardial surfaces, such as chordae tendineae and endocardium surface can be involved. Postmortem studies describe mulberry-like clusters of varicose on ventricular surface of posterior mitral leaflet, often with adherence of mitral leaflet and chordae to the mural endocardium. Clinical presentation and evaluation. So patients are often asymptomatic and cardiac murmurs are infrequent. We can see maybe less than 50% of the patients. Fever is uncommon, and when present, it might indicate just underlying malignancy, not the endocarditis. The major clinical manifestations from systemic emboli rather than valvular dysfunction. Up to 50% of patients presenting with embolic phenomena, and that is what the clinical suspicion's importance comes. Common sites of embolization include spleen, kidney, skin, and extremities. Emboli to CNS and coronary arteries are more likely to take to diagnosis because the presentation is more worrisome and more fast. In one case series, stroke was the presenting complaint almost in 60% of cases. So diagnosis obviously requires a high degree of clinical suspicion, plus all clinical condition we should keep in mind which are associated with this condition. In a patient treated for infective endocarditis but not clinically improving. So Mackay and Weller proposed a triad for diagnosis. Presence of a disease process known to be associated with NPTE. So first we should know all these conditions, we should keep all these conditions in mind. Then presence of heart murmur may or may not be present. Then multiple systemic emboli should definitely lead us a clinical suspicion higher side. And main differential diagnosis is infective endocarditis. However, distinction is important. So there are clinical features and diagnostic investigations which differentiate the two. Now, NBTE, commonly predisposing conditions is autoimmune malignancy and hypercoagulable state, while endocarditis infective normally involves underlying valve pathology, history of intravenous drug abuse, or indwelling catheters. Fever commonly in infective endocarditis, while systemic embolism much more common in NBTE. Heart failure rarely seen in NBTE, more commonly seen in endocarditis, and valve dysfunction is also very less seen in NBTE in comparison to the endocarditis. Now, diagnostic workup in blood culture negative endocarditis. So, when we suspect infective endocarditis, we take blood culture. If it comes negative, then we should send it for serological analysis for Brucella, Coxiella, Bartonella, Trophirema, Mycoplasma, Legionella, and Aspergillus. If this also comes negative, then we should again send blood PCR for ruling out completely Staphylococcus, Streptococcus, and Trophirema. If this also comes negative, then we should send for analysis for non-infective endocarditis, that is anti-nuclear antibodies, anti-phospholipid antibodies, anti-pork antibodies, and investigation for a malignant tumor. The absence of typical organisms that cause culture-positive endocarditis and atypical organisms that cause culture-negative endocarditis helps support the diagnosis. Appropriate number of negative cultures in culture medium, as has been already spoken about, is should be adequately excluded. And PCR with serology for the organisms that cause culture-negative endocarditis is must before we can diagnose it. A workup for antiphospholipid syndrome, testing lupus anticoagulant, antiphospholipid antibodies, DIC, should be done in every suspected case of NBTE. A search for malignancy, SLE, age-appropriate cancers should be done. CT or MRI may be performed in suspected cerebral embolization due to NBTE. The embolization in this case is widely distributed, multiple small and large strokes, but this is not a specific feature of NBTE. And strokes are classically ischemic, but hemorrhagic transformation can take place due to anticoagulation. Diffusion-weighted MRI can differentiate cardioembolic stroke caused by infective endocarditis from that of NBTE because there is a lack of cellular component in NBTE emboli. So we should specifically order that. TE has a higher sensitivity, about 90% than TTE, especially for vegetations less than 5 millimeters. There is significant and diffuse thickening of leaflets or cusp of the involved valve in NBTE, which may help differentiate between endocarditis and NBTE. Among those with NBTE who had also had a TTE and TE, TTE missed visitations in 4 cases out of 9. So coming to the treatment strategies in NBTE, we have three approaches: treatment of underlying conditions, anticoagulation, and surgery. So underlying condition, as we have seen, SLE, autoimmune conditions, we require immunosuppressant therapy under the care of a specialist. Malignancy, chemotherapy, radiotherapy, whatever is appropriate. Then advanced malignancy, just we may be giving palliative treatment. Anticoagulation, all patients should be coagulated with low molecular or unfractionated heparin or warfarin unless contraindicated. Obviously, we do cerebral imaging before to rule out the hemorrhage or any deterioration in the neurological signs. And management has to be with the stroke team. Surgery is seldom required since the valve is usually undamaged and may be considered in patients with hemodynamic instability or refractory heart failure. Consider if recurrent thrombotic valve lesions despite anticoagulation or vegetation with high embolic potential. So surgery with valve debridement or excision is infrequently performed, but may have a role in some patients who do not have advanced malignancy. Anticoagulation, patient should be anticoagulated with therapeutic dose of heparin, as I just now mentioned. Direct thrombin inhibitors, etc. are not given. And anticoagulation should be continued indefinitely because there is recurrent embolism. The indication for surgery, as I just now mentioned, heart failure, acute valve rupture. Preservation of valve may be possible because the vegetations are sterile. So treatment of underlying conditions, SLE. Optimal follow-up in these cases has not been defined. However, during therapy, patients may be followed clinically for complications to NBTE. In addition, echo at a defined period, example 6 weeks to 3 months, should also be considered to follow progression or resolution of valvular vegetations. Prognosis is grim despite anticoagulation due to strong association between NBTE and advanced malignancies. In patients with SLE, one 6-year longitudinal case cross-section study reported poor outcomes due to recurrent strokes, cognitive disabilities, and death. So to conclude, NBTE is an uncommon disease entity that occurs not only in patients with end-stage neoplastic disease, but also in those with potentially treatable diseases. We should raise our level of awareness of this condition so that a diagnosis can be made before the patient dies and anticoagulant treatment can be started, thereby helping to improve prognosis. Should be suspected in every patient presenting signs or symptoms of peripheral embolism with an associated debilitating disease, and transthoracic echo should be performed to attempt the confirmed diagnosis. If clinical suspicion is very high or TTE window is inadequate, then T should be strongly considered. Thank you.